Good morning, good afternoon, and good evening, everyone, and welcome to our webinar titled Optogenetic Stimulation for Parkinson's Research, Recovering Movement in an Animal Model. This webinar has been sponsored by 80 Instruments and was produced in partnership with the American Physiological Society, so a big thank you to them both for helping to make this event possible. Joining us today, we're very fortunate to have Dr. Louise Parr-Brownlie and Dr. Conor Underwood from the University of Otago to share a surgical procedure overview and engage in a discussion about the impact of acute optogenetic stimulation for the treatment of Parkinson's disease in a rat model. And now, without any further delay, I'm very pleased to welcome Dr. Louise Parr-Brownlie to the floor. Louise, take it away whenever you're ready.
Thanks, Sarah. It's a pleasure for Conor and I to be here today sharing our experience to help develop the optogenetic stimulation device and also what we've been learning as we've been using this technology. So the learning objectives for today is that I'll explain why a chronically implanted optogenetic stimulation device was needed. We will explain the surgical procedure to chronically implant the device, and we'll also explain some tips and tricks for post-operative management. So first of all, why did we want this device to be developed? And I'm going to start by explaining this from a clinical context within which all this work fits. So about 15% of people in Western societies live with brain conditions where there is death or overactivity of brain cells that causes conditions like Parkinson's disease, dementia, chronic pain, and epilepsy. In addition, another 15% of people have been diagnosed with mental health conditions such as depression, anxiety, and schizophrenia. For most of these people, they can be treated or their symptoms managed by behavioural and psychological therapy and or medication. But some people don't respond, and for these people, their intractable symptoms can be treated by surgical interventions. And today we're going to be talking about deep brain stimulation and what might become the next generation of this treatment, optogenetic stimulation. Deep brain stimulation was approved by the US Food and Drug Administration in 1996 and is now used to treat many brain conditions, including Parkinson's disease, which is the focus for this talk. The site that's targeted depends on the condition and also the symptoms that the person experiences. In all situations, a frame is attached to the person's head. The person goes into an MRI scanner so that the target site can be really well targeted and identified. And then the surgical procedure is done where an electrode is placed into that target structure. The wire is fed underneath the skin to a pacemaker that's placed into the chest region. Deep brain stimulation is incredibly effective. However, for Parkinson's disease, about 33% of the people that receive this technology end up with side effects such as depression, dysarthria, impulsivity, and cognitive decline. Optogenetic stimulation is selective, and so that's the benefit of why we're developing up this technology. So first of all, why do patients end up having these side effects with electrical stimulation? In part, it comes down to the placement. It also comes down to the current spreads between the active electrodes on the electrode. And although they can control the amount of current that is applied, we can still have neurons or fibers of passage where these cells arise from a different part of the brain, controlling a different function, and happen to just cause close to where the stimulating electrode is, and therefore can trigger these side effects. Ideally, we want to reduce the side effects, and so this is why optogenetic stimulation is being harnessed. So the advantage is that we can use a technology where we can actively stimulate only one type of cell, possibly in only one brain region, and therefore we have really tight precision control. And the way that we do that is we're going to get a light responsive protein or an opsin into a cell, this top cell on this right-hand side of this figure, and then any pulse of light is going to activate or modulate the activity of that cell. Now, if we were doing this with only focused on animal experiments, we might use a transgenic animal in order to express our opsin in our target region. However, if we're going to start preparing for the translation to humans, then we wanted to be able to control, we had to be able to use a viral vector in order to be able to express our opsin of choice. So what we did was we used a lentiviral vector. We took out its genetic code and we put in the genetic code that controls for or makes the opsin express, plus we can target it to glutamatergic neurons because they're the dominant cell type in our structure of interest. And we also have a reporter protein, so we know where it is actually expressed in the brain. So the virus is injected into our target structure. In that region, the opsin is then expressed in the membrane of the cells. And then once the expression is robust in those cells, when we flash a pulse of light, blue light in this case, the channel rhodopsin will open. The cell will be slightly depolarized momentarily, and we can create an action potential. And the key thing is that with this technology, we can control the flashes of light, and therefore we are trying to recover a function such as movement. This slice is through the human brain. It includes the motor pathway that's the focus for the experiments that we do. So what we see here is the cortico-basal ganglia thalamocortical pathway. And cells within this pathway need to be activated at the right time and in the right order in order for a precise movement to occur. In Parkinson's disease, dopamine cells die off, and these dopamine cells are located in the basal ganglia. And as a result of that, activity changes within and between these structures and movement deficits occur, such as akinesia, which is difficulty initiating movements, and bradykinesia, which is when the movements are much slower. So in order to restore movement, what can happen is that the deep brain stimulating electrode is placed into the subthalamic nucleus, and when that is done, we know that the person's movements are recovered, and in some of these structures we see normalization of the activity in the structure as well. Well, we didn't want to target our stimulation therapy there. We wanted to target it in the motor thalamus. And the reason for that is that is located between the basal ganglia, where there's the loss of the dopamine, and the motor cortex, which is where the precise motor plan will be developed before it goes and descends down the spinal cord. Now, something that was important about this structure is that, yes, it does innervate the motor cortex directly, but when these motor thalamus cells are stimulated, they tend to increase the excitability of neurons in the motor cortex, but they don't directly activate them. And what's great about that as a therapy is that it means that these motor cortex cells can listen to all the normal inputs it normally receives to help develop up this the motor program for the movement. Something else that we did that was a little different was we applied really different patterns of stimulation. So normally when the deep brain stimulation is applied to the subthalamic nucleus, they use very high frequency stimulation. The example that we used was 130 Hertz. However, the brain doesn't work like that, and we wanted to start teasing out if more complex patterns might actually recover function more effectively. So the first pattern that we used was theta burst stimulation, where there are 5 stimuli applied per second. But first of all, we had them collected 3 stimuli in a burst, and we applied 5 bursts per second. In addition, we had previously recorded neuronal activity from the motor thalamus when a control rat had been executing a reaching task. And if that neuronal activity is really important for controlling the actual movement, then we wondered if we replayed that back into the brain, whether we might better recover function, or the reaching function in particular. So we used the timing of that previously recorded spike train to trigger when the blue light stimulation was going to occur. And then finally, we also used rate controls to tease out whether theta burst stimulation and that reaching pattern, whether anything that was effective was due to the number of stimuli per second, or the rate, or the precise timing, the pattern of the stimuli. and what we found. So the experiment that we did was we made our rats Parkinsonian just acutely by injecting the dopamine 2 receptor antagonist haloperidol. And we did parallel experiments where the same rats received a vehicle injection. And when they did that, they executed about 200 reaches per 5-minute block. But when we injected haloperidol, what we found is that the number of reaches reduced significantly down to about 20 reaches per 5-minute block. And to show you what that really looks like and that these rats are Parkinsonian and not really moving at all, I'm going to start this video, which shows you that the rat's head is moving up and down. It's orientated to the feeder tube where food is located, but it doesn't actually execute any reaches in this 10-second snip of video. Right, so from there, that was our baseline period. We then applied 2 10-minute periods of blue light stimulation. We applied several different types of patterns, but I'm only showing you the data from 3. So the 130 Hertz tonic pattern was ineffective, but both feeder burst stimulation and the reaching pattern significantly increased the number of reaches that the rat executed. And to show you what that looks like, I'm showing you the same experiment, the same rat, later on after 20 minutes of blue light stimulation. And what you see if you look into this feeder region is that the rat is reaching for food and it is able to obtain it and it is able to eat it. So we've actually recovered that movement that will reduce the movement deficit. So now that we've found that motor thalamus stimulation can recover function, we were starting to think about how we might actually use that or apply that knowledge. So if we wanted to move towards optogenetic stimulation, we needed to change the technology because, first of all, parts of it weren't available. So the human brain is 600 times heavier in weight. It's significantly larger than a rat brain. And so we needed to change the technology to allow for being able to stimulate a larger area of brain. So we would need to change the viral vector and also the opsin that we're likely to be using in order to get enough light into the brain region or the target region. But in addition to that, our biggest problem when we started this experiment is that we didn't have a device. So normally deep brain stimulation, the stimulator is inserted, it's in the person for a long period of time, more than 5 years usually, and then the stimulation is applied for 24 hours a day in order to treat the movement deficits. So what we needed was an optogenetic stimulation device that was, first of all, implantable, had a battery that could be recharged periodically, and the battery lasts for a long period of time, at least months in our rats, and preferably when it goes to humans for years. And then because of our previous experiment, we wanted to be able to apply really complex patterns of stimulation. Now, at this point, we were fortuitous and we had been talking to some bioengineers up the other end of New Zealand, and we realised that they had developed the hardware and were starting to develop the software in order to control an optogenetic stimulation device. And so what we did is came in, started to take that technology and feed information back so that we could refine it so that it became a very usable product. So in a moment, we'll hand the talk over to Conor, but before we do that, we're going back to Sarah so that she can run some polls.
Okay, and so without any further delay, I'm pleased to welcome Conor Underwood to the floor. Conor, take it away whenever you're ready.
Thanks, Sarah, and thanks, Louise, for giving some context for why we wanted to use wireless optogenetics in our research. So what I'm going to talk about is really just the technical considerations for if someone wanted to use this device. And so when deciding what to talk about here, I've assumed that most people will have a basic understanding of rodent surgery and probably some experience with stereotactic surgery. And indeed, if you wanted to use this device, a kind of fundamental skill that you need is some competency in stereotactic surgery. So as Louise said, we have been using this optogenetic telemeter to provide continuous optogenetic stimulation of the motor thalamus for many months in rats. So the first thing I want to touch on is, if you want to use this device, there are things you need to consider before even purchasing the device to see if your particular lab or your experiment is compatible with the optogenetic telemeter. So the first thing to consider is what drugs you'll need to use for the implant. So you really need to be able to deliver isoflurane anesthesia, gas anesthesia. We tried this implant procedure with an injectable cocktail, ketamine domitor, and really we did not have much success. You know, you can get the animals to survive, but more often than not, they just do not recover properly from the surgery. And of course, with any rodent surgery, you need an ability to deliver antibiotics, particularly prophylactically in this case, and analgesics. So carprofen, but we also use opioids as well, but buprenorphine. The second thing to consider is the weight and the strain of the rats that you need to use. So if presumably you would have done some stereotactic surgery before, and you have a brain region that you're interested in, and you know what coordinates reliably target that brain region for a particular rat strain and a particular weight. The key thing with using the implant is really you can only use it in animals that are above 300 grams. And so if your coordinates are optimized for 200 to 250 gram animals, you really need to reconsider what those coordinates are, or what they need to be, if you want to use this particular device. The third thing is specialist equipment. So there's not much additional specialist equipment you need to use this device on top of what you would already have for stereotactic surgery. But there are two critical things. So you need a trocar. You either need to buy one or make one yourself. We made one. So this is just basically a stainless steel rod that's hollowed out. The outer diameter is about 10 mil and length about 200 mil. And we attach a smooth bevel on the end. And this trocar, we use it just to create a subcutaneous tunnel from the belly to the head so that we can feed the cables originating from the telemeter that's located in the belly to the head of the animal during the surgery. The second tool that you'll need is a stereotactic insertion tool, but one that's in an open configuration. And so most labs would probably, in this figure here on the right-hand side of the slides, most labs would probably have a tool that looks like that on the left. And that's really not going to work, because if you use that to grasp the fiber optic and insert it into brain, you won't be able to retrieve it afterwards. It needs to be in an open configuration, like the one on the right. So, another couple of tricks here. So, the first one, when you're preparing to use the telemeter, when you're preparing for your implant surgery, there's two things or a couple of things that we do. Firstly, we attach a cannula to the end of the fiber optic. So we target quite a deep brain region, about 6 mil deep from the brain surface. And so we use a stainless steel cannula at the end of the fiber optic just to guide the fiber optic into the brain and ensure it goes in perfectly perpendicular to the brain surface. And we also use that stainless steel cannula so that we can grab the fiber optic during surgery and not damage it. Okay. So the second thing that I would recommend is to coil the fiber optic and tie it off. And so when you get this device, you'll see that the fiber optic is basically too long. And that's just so that you can reuse the device in multiple animals. Because when you reuse it, inevitably what happens is you trim the fiber optic each time. And so if if you have an excess of fiber optic to begin with, you compensate for that. But the problem with having a really long fiber optic is it tends to accumulate in the abdomen of the animal and can kind of entangle with the gastrointestinal tract, which is not a good thing. And so what we do is we create this coil tied off with silk suture. And that coil basically will live in the subcutaneous space above the abdomen and will prevent this excess fiber from entering the abdomen. Okay, and of course you'll have to sterilize or disinfect the telemeter. If you have access to ethylene oxide, great. That's kind of the gold standard. But using a high-level disinfectant like Sidex OPA is perfectly fine. That's what we use. And the fourth point here is you really need to familiarize yourself with the physical properties of the fiber optic. And what I mean by that is know how much you can bend the fiber optic before it snaps. Because during the implant surgery, you will have to bend the fiber optic. And if it snaps, it's really game over. Okay, so now what I'm going to do is go through the procedure generally and highlight kind of key points that are quite unique for this device. And I guess I'm hoping that this will enable anyone to, once they've purchased this device, to use it effectively and not have to do an absurd amount of troubleshooting. So, of course, the first thing we do is we anesthetize and prepare the surgical sites. It's really important to betadine wash the belly and the head where you'll be making incisions. And then we lie the animal in the supine position and implant the telemeter body in the abdomen. And then we feed the cables coming from the telemeter, so the fiber optic and the bipotential cables. We feed those cables to the head, perform the stereotaxic surgery, build the dental cement headpiece to protect the various cables at the head, and then close the abdominal wound and wake the animal up. And so now I'm going to show some videos and images of various points in the surgery that are quite unique with this device. So the first video that I'll show illustrates the typical size of the incisions we make in the belly, both in the skin and in the muscle wall. And so we make a midline incision. In this image here, the head is located in the bottom left-hand corner. And so I'll play the video now. And so we insert the device. Basically, we want the device to be in the lower left quadrant of the abdomen. And that's just so that we can avoid both the liver, which is in the upper half, but also the colon, which is in the bottom right-hand side. And so you want the device to sit on top of the viscera, and you don't want any of the GI tract to be located in between the device and the muscle wall. And so what I'm doing here is just getting the position of the telemeter right before proceeding. And there's two tabs on the telemeter, which we use to attach silk suture to secure the device to the muscle wall, but that's not shown in the video. Okay, so once the device has been inserted in the abdomen, and then close the abdominal wall with monofilament dissolvable suture, And the critical thing here is that the cables go in between two sutures. Okay, if they are located at either edge of the incision, then it's going to create a lot of tension on the incision site, and the muscle might not heal properly. Okay, so the next step is then to tunnel the cables, the fiber optic and the biopotential cables, from the belly of the animal to the head of the animal. The first thing you'll note in the still image here is the coil on the fiber optic. Okay, so it's tied off at a point that enables it to sit within the subcutaneous space, directly on top of the belly. So I'll play the video, and the first step here is to blunt dissect around the belly of the animal, and then also moving laterally towards the ribs. And you basically want to blunt dissect as much as possible. You won't be able to blunt dissect towards the head of the animal because you just won't be able to get there. You know, we have quite long scissors here, but it's still not enough. And so that's when you really need the trocar. And so the next video shows the insertion of the trocar tool. So it's a steel rod that's inserted from the belly of the animal through the subcutaneous space to the head, and allows us to feed the cables up towards the head. So if I play the video, so I insert this pipe around where the area that's been blunt dissected already, and then slowly advance the pipe up towards the head. And this is why you need the bevel on the end. And you don't want that bevel to be too sharp because you don't want to pierce the skin. You just want to be able to move through the subcutaneous space. And you'll be able to see where the pipe is under the skin. And so I can see now it's just moved to the head. And once I can see that the tip of the pipe or the trocar is close to the head, I get a scalpel blade and make a small incision at the head, just so I can pop the trocar through the skin there. And so now we have a tunnel a subcutaneous tunnel from the belly to the head. And now what that allows me to do is to insert the fiber optic and the biopotential leads very carefully through that tunnel. I lead with the fiber optic because you do not want the tip of the fiber optic to touch anything but brain. Okay, so I follow that with the biopotential leads. Okay, so once the cables have been inserted into the trachea towards the top of the head, the next step is you want to proceed with the stereotaxic surgery to position these cables, to position your biopotential leads. We use them for EEG, but you can also use them for EMG or various other biopotentials. And we want to insert the fiber optic into brain. So for the stereotaxic surgery, we keep the abdominal skin open. And that's just because at later stages of the surgery, we want to come back to this incision site. We may need to adjust the cables. So we want to have access to the abdominal wound at a later stage of the surgery. And so for the stereotaxic part, we want to protect the abdominal wound from unsterile things to prevent infection. And so what this video shows is how we protect that area during the stereotaxic surgery. So I put sterile gauze on the area and then fold the sterile drape around that area. So now I can remove the animal from the surgical space used for the abdominal surgery and put the animal in the stereotaxic frame without breaking sterility. So that's what the next step shows. So this is a really kind of time critical part of the surgery, because we have to remove the animal from the isoflurane gas, flip the animal and put it in the stereotaxic frame, and then reattach the isoflurane gas. So this has to be done really quickly. You've got about 20 or 30 seconds before the animal starts to wake up. And so it's critical to get the area ready. So get the abdominal area ready, like I just showed you, put the sterile gauze in, get all the gas lines ready, and make sure you're ready to flip the animal and put it in the stereotaxic frame. That's what the next video shows. So I'm just getting all the pipes ready so that the gas is now not going to the animal but going to the stereotaxic frame instead. Once that's ready, you can very quickly remove the animal, protecting the abdominal area, and get the animal in the earbuds. This is something that really needs to be practiced again and again until you can get this done in 20 to 30 seconds. And I leave the trocar in here because it protects the fiber optic and the biopotential leads from damage and from unsterile things as well. So it keeps the cables sterile during that procedure. Okay, so once the animal's in the stereotaxic frame and on the gas, you can then get ready for stereotaxic surgery. So what we do is we use a sterile drape placed over the animal, and you can just pierce the trocar through the sterile drape. And then once the sterile drape's on and you can see the tips of the cables out the top of the trocar, you can then slowly remove the trocar. And then you keep your fingers and toes crossed that the cables stay in place when you remove that trocar. Okay, and then stereotaxic surgery, proceeds as normal, really. We identify lambda and bregma, get the skull in the flat position. We make a burr hole over the thalamus, quite a large burr hole, so that we can do our virus injections, but also then position the fiber optic into that hole. We position about 7 or 8 skull screws. And these serve two purposes. So the first purpose for us is we use the skull screws to record EEG. So we wrap the positive biopotential cable around a skull screw placed strategically over the motor cortex, and the negative biopotential lead we wrap around a screw placed over the cerebellum. The second purpose of the skull screws is they provide an anchorage point for the dental cement that we will apply and form a headpiece for this animal. And we find that really you need at least 6, but we put normally 8 screws to provide anchorage, because it's really quite a big headpiece. And while dental cement does adhere to bone, it's not perfect, so we really need those skull screws. Okay, so after doing the bulk of the stereotaxic surgery, the final bit is to insert the fiber optic into your brain region. And at this stage, you need to manipulate the fiber optic to get it into the stereotaxic arm. And as part of that, you're going to have to bend the fiber optic cable. And so it's really critical to know how much you can bend this cable before it snaps. So this video shows how we do it. Okay, so we have a stereotaxic needle holder in the open configuration. We get that holder positioned so that you don't need such a long length of fiber optic exposed. And here I'm just getting the cable ready for the bend. And if you feel like it's if the bend angle is if it's too much and it's about to crack, you can just pull out a bit more fiber optic to kind of compensate for that. And so once it's in place with one hand, and then get the other hand and screw it into place. Okay, sorry, my hand occludes the view here. Okay, and so now that's secured and ready to be inserted into brain. If you're not using a cannula at the end of your fiber optic, you really have to be careful with how much you tighten the clamp, because you can crack the fiber optic. Because we're using a cannula, it's not such an issue. Okay, so once the fiber optic is inserted into brain, it's then time to build up a dental cement headpiece. So these still images here show how we do that. So the first layer of dental cement that we apply is really quite thin. That's just to cover the burr hole through which the fiber optic has been inserted, and to get good coverage over the various skull screws. And then the second image here, we build that up a bit more, and then once that dental cement is hardened, we can remove the stereotaxic holder in 3. In 3, that also shows that I use a silk suture to retract the fiber optic. And that just basically facilitates how I build the headpiece with dental cement. Basically holds the fiber optic in place to allow me to build dental cement around it. And 4 is kind of the final product. And the aim of the game here is just to have enough dental cement to cover all the cables, both the biopotential cables and the fiber optic, but not too much. You want to make this headpiece as small as possible so you don't impair the behavior of the animal. And you also don't want any sharp bits, particularly close to the skin, because it's not going to be particularly comfortable for the animal. Okay, and then once the headpiece has been formed, we then flip the animal over so that it's in the supine position again, and then close the skin at the abdomen. There's a couple of ways you can do this. When we first started doing this procedure, we were using surgical clips, but we found that a lot of animals will remove at least one clip, and some of them would then go on to develop infections. So we moved to a method where we closed the skin around the belly with a buried intradermal continuous suture. Go to YouTube and learn how to do this. We have not had any problems with this technique. It's quite technical, and you've got to practice it a few times on a cadaver. But yeah, it's really has it's never failed us, basically. And just as an added layer of protection, we use surgical glue over the top of the suture. Vet Bond by 3M is really good. Okay, so the animal survived the surgery. What's next? So there's various things you can do to enable kind of post-surgical recovery of your animals. So first thing is you want to modify the home cage. So the animal will now have a big headpiece. It can get caught on things and it can be removed. So accommodate that. So in our experience, we find that the feeder boxes in our head cages basically need to be removed. because the headpiece can get caught on them. But also the domes that the animals sleep in, they need to be high enough for that headpiece. The telemeter charges through a wireless system, and the capacity to charge really depends on how close the animal is to the charging pad underneath the cage. So what we found is that some cages kind of have a warp in them, which really impairs charging. So look out for that. And another thing that we found is the combination of buprenorphine and abdominal surgery can induce something called picker behavior in about 10% of animals. And what this is animals eat things that they shouldn't be eating, and it can basically lead to death. So what we find is that they will eat their corn or wood bedding. So the approach is basically to remove hard bedding and replace it with cotton wool for at least 5 days when the animals are on buprenorphine. Okay, so of course you're going to tackle pain and infection prophylactically. We give analgesia and antibiotics for 3 days post-op. From time to time, probably 10 to 20% of animals, we continue carprofen for 5 to 7 days. And that's just because in those animals, 10 to 20% of animals develop a seroma around the abdomen. It's just a build-up of fluid, and the carprofen really helps with that. We've never had a problem with it, but it certainly helps reduce swelling in the abdomen. Okay, and the final thing to keep in mind is you want to protect the implant. If you see that there are any exposed wires, or you can see the fiber optic, particularly at the rear of the head, you might need to re-anesthetize the animal and patch up the dental cement headpiece. And keep an eye on the abdominal wounds. If they're exposed during that first 5 days post-surgeries, get on top of it early because you don't want an infection. Okay, so you can reuse these telemeters. So in our experience, we've used them twice. So we'll put a new telemeter in an animal, perfuse the animal, and reuse that telemeter. It really depends on how much you have to trim the fiber optic after explant, which ultimately will reduce the length of the fiber optic each time, and it'll get to a stage where it's not long enough to be used again. So you can perfuse animals with implants, that's fine. With fixative, that's fine. When you're dissecting the implant out, you have to be really careful not to cut any cables. So we try to use scalpel blades wherever possible, and not scissors. And when we do use scissors, we blunt dissect rather than chop, because the amount of times a fiber optic will just come out of nowhere and you'll cut through it, it can be quite frustrating. Okay, so there's kind of two options you can take when explanting the telemeter. We take option one. It's kind of the easiest and least time consuming. And that's, with this option, what we do is we cut the cables at the back of the head, towards the headpiece, dissect the body of the telemeter in the abdomen, and then pull the telemeter out. And as I've been saying, that limits the lifespan of the telemeter because each time you use it, the length of the fiber optic gets shorter and shorter. The second option that we tried a couple of times, didn't have much success, is you can actually remove the entire headpiece, don't cut any cables, and then dissect the entire length of the fiber optic and the biopotential leads, dissect the body of the telemeter and remove the whole thing with the headpiece attached. And then you can actually dissolve the headpiece in acetone. You don't want to put the telemeter in acetone, but you can dissolve the dental cement in acetone if you leave it in acetone for 3 to 5 days. The risk with this procedure is the time it takes to dissect the telemeter and the procedure for dissolving the headpiece can lead to cracking of the fiber, and it's not always at a nice place. You could crack the fiber close to the body of the telemeter, which basically makes that telemeter unusable. So it's kind of a high risk and high reward option two. Okay, so that concludes my part of the talk. I'll leave you with some acknowledgements. So we would like to thank Associate Professor Stephanie Hughes, whose lab produces the virus for our work. Professor Dirk de Ridder, who is a neurosurgeon who provided some strategic advice for this project, and other members of the Parr-Brownlie lab. And we also want to thank our bioengineer collaborators who developed this technology. And without them, we wouldn't have been able to do this experiment. Okay, thank you very much.
Louise and Conor, thanks so much again for your presentations, and I'm really excited to get into this Q&A. We've got lots of great questions coming in here. So somebody in the audience has asked, why is the open configuration for the stereotactic frame better for implantation?
Yeah, so essentially because both ends of the cable, so the fiber optic cable that you're using the stereotactic tool to insert, the fiber optic into the brain, and it's connected to the animal in both locations, at the one end and at the other end. Okay, one end goes into the brain and one end gets buried underneath the skin. And so it needs to be in an open configuration so you can remove it afterwards. If it's in a closed configuration, it's going to be stuck on the animal. You're not going to be able to remove it unless you can cut into it and remove it, and then it's single use. So yeah, it's really critical that tool is, as I said, in the open configuration.
Okay, great. Thanks for clarifying that. Another question here. This one, well, there's a couple of them, so I'll kind of summarize. This one is asking, do you need transgenic animals for this type of work?
It's not a requirement, no. We use rats, and most commonly for rat work using opsons, we'll use a virus to deliver the transgene. Simply because there aren't that many transgenic rats. It's not like mice where there are lots of different transgenic rats to suit your purpose. It's far more common to use viral vectors to deliver the transgene. So in all of our work, we use viral vectors instead of transgenic rats.
Okay, perfect. This question has come in that is asking, how long do you wait after making the headpiece before closing the abdomen?
Yeah, so we build the dental cement headpiece over about 45 minutes, and we do it incrementally. And so by the time you're putting the final layer of dental cement on, all the other layers are completely cured. So really, you only need to wait a couple of minutes after you apply that final layer, before which you can flip the animal over and continue with the rest of the surgery. Yeah, so not long at all. But I think it does depend on what type of dental cement you're using. We're using acrylic dental cement. I can't comment on any other form of dental cement.
Okay, perfect. And then there's a second part to that question. How are you closing the skin surrounding the dental cement, particularly the incision made by the trocar?
Yep. So the incision made by the trocar is really, it's really only towards the head. The whole idea of the trocar is so you can bury a tunnel, a subcutaneous tunnel, and not have to make a big incision at the head. We close, so after we've built the dental cement headpiece, or while we're building the dental cement headpiece, we take time to just close both ends of the head incision with a couple of discontinuous sutures, just like you would in any other stereotactic surgery. We use dissolvable suture material just so we don't have to go in afterward and remove those sutures. And really, you only need maybe one at the front towards the nose and maybe 2 or 3 at the back of the head. And it's just the ones at the back of the head is really just so you completely disguise those cables.
Protect them from getting gnawed on by their cage mates.
Yeah, or scratched, particularly by the animal. If they scratch the back of the neck, you want to protect the cables, particularly the fiber optic, which from time to time we have experienced snaps at the back of the head.
Okay. Good tips. Thank you. There's a question here that's asking about the stability of this telemeter while the rat is freely moving.
The stability of the stimulation, it's completely stable. It does not drop out. The biopotential, I think it depends on what you're recording. We do EEG. We have done EMG as well. With EEG, we only get artifacts with chewing, and that's quite normal with EEG, no matter what system you use. So really, it's super stable, and I would say even more stable than tethered systems simply because the fiber is shorter, the cable's shorter, and completely contained within the animal. So there's nothing for the animal to tug on, as it were. And our experience with EMG, when we did a couple of EMG experiments, it's completely stable with the animal moving. Of course, if you're recording EMG, you get changes in the biopotential with movement because you're recording muscle. But in terms of artifacts, it's completely stable with movement.
Yeah, makes sense. Great. Okay. And we do have time for a couple more questions here, so I'm going to just plug on. This next question first says, thank you for an interesting talk. And then the question is, in your experience, what is the longevity of the biopotential implant? In our experience, rodents tend to scratch out their EMG implants, in particular after a couple of months, making it a problem for chronic studies.
So as I just said, we've only done EMG implants in 2 or 3 animals. But in all those animals, it lasted for months. I mean, it didn't fail us, right? So we kept the animals for, I think, 2 months in 2 rats, and in 1 rat we kept for, I think, well over 6 months, and the recording was totally fine. Yeah, we had no problems with it. And certainly I didn't experience the animals scratching at the implant. So for EMG, we just we get the biopotential channels and we suture the positive biopotential lead and the negative biopotential lead directly to the muscle. There's no additional electrode attachment per se, other than the raw biopotential cables that we suture to the muscle. And we certainly didn't experience the animal scratching it, or I have no concern that it's not comfortable for the animal at all.
Great. Okay, there's 2 more questions here. So this one's a quick one. Can we use ketamine xylazine instead of gas anesthesia for this procedure?
You can, but you probably won't have much success. When we first started doing these experiments, we were using ketamine xylazine. And in most animals, you can get them to survive the procedure. So the procedure takes anywhere between 5 to 6 hours in a trained surgeon. And, in 80% of animals, you can get them to survive the procedure, but they won't make it overnight. They just do not recover completely from the surgery. So most of the animals will die overnight. It was a light bulb moment for us when we changed to isoflurane. Every animal almost survives the procedure and will survive overnight. That's the strongest recommendation I can make. Do not use ketamine xylazine. Use isoflurane.
Mm-hmm. Yeah, definitely. Awesome. Okay, and my last question, and Louise, I'm going to direct this to you to start. Where do you see the future of this technique going?
So, optogenetic stimulation, there's good evidence that viral vectors will last in primates for longer than 10 years, and viral vector technologies have been used successfully and shown to be safe in humans, but not for optogenetic stimulation as yet. At the moment, the only place that I know that there's optogenetic stimulation that's been done in people is to do with blindness and to recover some sight. But I think it's only a sort of a length of time, really, until we've got all the pieces together and somewhere it is trialled in the world.
Great. And Conor, what about you? Any other thoughts?
My final thought would be that I think as we get better and better with using optogenetics and we can translate it to humans, we're going to see more and more clinical studies using this as a replacement for electrical deep brain stimulation. And I think that's going to reveal a whole bunch of interesting things, particularly the efficacy profile compared to electrical stimulation will be different, and the safety profile, I think, will be vastly different. We can't predict what that safety profile and what that efficacy profile will be like, but I will just say it will no doubt be vastly different because of the differences in the specificity and the fact that with optogenetics you can be confident in what you're actually stimulating. With electrical deep brain stimulation, you really cannot be confident in what you're actually doing to the brain.